and I'm joined by Dr. Hi, I'm Meredith Marr at the University of Maryland Medical Center, Midtown Campus, and I'm joined by Dr. Jacob Wynes, instructor of orthopedics at University of Maryland School of Medicine, podiatric surgeon and wound specialist at UMMC Midtown Campus. Thanks for joining us today.
Thanks for having me.
And thanks to all of you for watching. Please be sure to like this video if you're tuning in and to like our page if you haven't already. Dr. Wynes will be taking live questions from the audience, so you can leave your questions in the comments section under this video. So we're here talking about non-healing wounds. Explain to us what a non-healing wound is.
Well, anybody that gets cut or has an injury can develop a wound, and typically that wound should start its whole healing process right away, and then ultimately progressing to healing in about 5 days. Ultimately, that part of the healing process is pretty standard, but when you have issues related to diabetes or medical problems, then those things can get very much slowed down. There are different types of wounds. There's traumatic wounds, which actually, interestingly, only lead to about 2 to 5% of amputation. The rest of the wounds that we're more concerned about are the ones that could lead to an amputation or significant problems, and those can be mostly associated with diabetic foot ulceration, people with bad circulation like arterial disease, vein problems considered venous disease where the blood doesn't get back up to the heart where it belongs, people that are very swollen oftentimes, or people that have something called neuropathy where they don't feel very well, and ultimately they may walk around with marbles in their foot and not even realize it. So they often say it's what you don't feel that can hurt you.
What are some symptoms of a non-healing wound?
A lot of people come to me and they talk about, oh, the foot doesn't smell good. And I think oftentimes that can be not always a problem, meaning that it could just be like a moisture thing. It could be that you are just a sweaty person. And that might not mean a sign of a non-healing wound. But if that wound is draining or it looks more yellow than it does red, red is good. Yellow is very bad. So if a wound has a lot of yellow, then that could mean that there's a lot of colonization of even what we call fibrous tissue, which is almost like plaque on teeth. Much like people have to brush their teeth, you should also have the ability to take away this bacteria from your skin. And even though we all have bacteria that are on our skin that can be good, if it gets into the wound, it can kind of stir the pot and make things very inflamed. And when the wound's inflamed, it gets very angry and doesn't like to heal. If you see redness around the wound, that can be a problem as well. The redness can oftentimes be associated with infection. So in addition to having a wound that, again, is less red and more yellow, that could be a problem too. Typically, it's also important to realize, is there a pressure point under that area? Or is the person walking a certain way? Or the bones are deformed in such a way that's putting excess pressure onto that site?
How quickly should one expect a wound to begin healing? Is it 4 weeks, 6 weeks, 8 weeks? When is it considered a non-healing wound?
A wound that doesn't heal in about 4 weeks is very concerning. There's literature to show that a wound that doesn't heal by at least half in 4 weeks is less likely to heal at 12. So with that knowledge, we know that there's probably something going on. And like I alluded to earlier, 3 to 5 days is ultimately where you should start to see some resolution of the wound. Wounds can heal from the ground up. I mean, I myself, I was just had a baby, but I was putting in a car seat, and I still have a wound, and this is like 3 weeks out, but it is healing, and as long as there's that steady progression to healing, I think you're okay. But again, malodor, meaning something that smells not quite right with drainage, can be a big warning sign. A lot of redness, especially if the redness kind of streaks or goes beyond the margin of the wound. And something that takes, I would say, no longer than about 7 to 10 days to really start to look good, I think could be considered a non-healing wound, especially if you have medical problems like diabetes, poor circulation, or especially a combination of the two.
Great. So just a quick reminder that if you're watching us right now, please like this video and like our page as well, and continue to leave your questions for us in the comments section. So why should someone go to a wound specialist versus just going to their primary care physician or their family physician and expecting them to be able to treat their wound?
Well, I think all physicians know that wounds are different, and the wounds typically require a certain degree of attention. Everyone that is a practicing physician should be able to differentiate, is the wound infected or is it not infected? I think once we get past that, I believe a wound specialist may have options to treat the wound, particularly at a wound center where they're able to see the patient more frequently. Studies have shown that a wound that just stays there and gets no treatment doesn't heal as well as a wound that gets debrided, meaning removing all dead or infected tissue off that wound. If the wound itself is relatively low maintenance, then I think a primary care physician is more than capable of handling the wound. But the wound center provides the added benefit of monitoring that wound weekly, but also allows for the patient to get accurate feedback week to week. We assess the wound, we measure the size of the wound every week, and as I talked about earlier, a wound that fails to heal by 50% at 4 weeks is less likely to heal at 3 months. So all that is very important. Plus we have use of what we call skin graft substitutes, or things that will provide a better environment for the wound to heal. Because again, the wound also requires the perfect balance of moisture too. It can't be too dry, it can't be too wet, and also somebody that's able to assess, whether it be your primary care physician or a wound specialist. The most important thing we have to ask ourselves is, why is the wound there in the first place? Again, figuring out why the wound is there and then going back, getting the diagnosis, and then starting the treatment, I think is the most important. So provided, even if you are a primary care specialist that doesn't deal with wounds on a weekly basis, as long as someone is aware and has enough knowledge to recognize why the wound is present, whether it's from pressure, bad circulation, is it infected, or is it just stuck in this inflammatory phase of healing, then I think they can certainly handle it. But I think a wound that has not demonstrated healing within a reasonable period of time, such as 2 weeks, I think should definitely be referred to a wound center or a wound specialist.
What can patients expect at their first?
Well, they can expect comprehensive care. They'll usually be brought in. A nurse will evaluate the patient. The provider will evaluate the patient. The wound will be looked at. It will be measured appropriately. Pictures will be taken of the wound. And from there, it's great because you can establish a nice baseline, see where the wound was and where it's going to head. Plus, you get the added advantage of somebody that could order you other tests to better determine why the wound is there. If you have a wound with exposed bone, that could mean that the bone's infected. X-rays are very good in that setting. We can do bone scans, MRI. We can do orders for non-invasive vascular testing, which what that is just a series of blood pressure cuffs that go around your leg. And with the help of our vascular surgery colleagues, we're able to provide multidisciplinary care, meaning that we're able to get people on board in addition to the wound specialist and may be able to help once we figure out why the wound is there. So to answer your question, a typical visit would involve waiting in a normal waiting room, hopefully not too long, and then being brought back to see both a nurse, a doctor, and a case manager, which will then also help you coordinate your care, because I believe that it's not set it and forget it type of medicine. I think you have to obtain and then you have to maintain. Very little of what I do at the wound center is half as important as the patient having the resources to take care of the wound during that week interval while I'm not there. Unfortunately, as much as I'd love to go home and hang out with the patients, I'm just not able to, but I feel that if you have the coordination of care that's appropriate through nursing and case management support, along with the physician kind of driving the ship, then you get the best care possible because you get your supplies, you get a good schedule going, and we also help coordinate with visiting nurses too if you're unable to take care of your wound yourself.
So you touched on this a little bit a few minutes ago, but what are some treatment options for a non-healing wound?
And again, first and foremost, the American College of Surgeons came out with a great article that looked at wounds that were just treated with normal, old school, pardon the expression, saline wet to dry, which is basically just taking a saline gauze and putting the gauze on the wound and then taking it off every day, which does provide some benefit because what you're doing is you're allowing the dressing to dry, and then with every removal of that dressing, you're able to remove the bad material, that fibrous tissue like we talked about, all that inflammatory stuff. Other things you can do that's a little bit better could be use of what we call enzymatic debriding agents, which are basically like a topical salve that you put on. You can put it on every day, and we let chemistry work for us while helping us break down the wound without having to rip off dressings. These are called advanced wound healing modalities, or things that we can use. There's all different types of things. There's a lot of potions and lotions out there. I think first and foremost, you have to offload the wound, appreciate why the wound is there, get the appropriate vascular workup, and really be able to assess what we're trying to fix. Sometimes wounds can be related to inflammatory skin conditions, which in that case I sometimes use topical steroids or even inject steroids around the wound to kind of help calm down the environment and get it more primed to heal. And lastly, I think hyperbaric oxygen has been shown to have some efficacy, particularly with management of bone infection or osteomyelitis, as well as other non-healing wounds or wounds that have enough blood flow getting down, but the capillaries are closed down and they need help opening up those capillaries or those small circulation connections that allow the wound to heal. Because a wound that has what we call poor perfusion, or the not very much blood flow getting down there, will never heal also. And then also lastly, I think offloading, basically putting the patient in something that's going to prevent pressure and shear that could break down the skin further. A wound, even after it's healed, is not entirely healthy with respect to its strength for almost 3 months. And it's only at that point that it's about 80% as strong as it once was. So we have to protect that wound even after it's healed.
Great. Let's take some questions from the audience. First, to do some introductions behind the scenes. We have Angela Jackson operating the camera and Sonia Hamlin fielding questions from the audience. They're both from the marketing department at UMMC Midtown campus. Sonia, do you have any questions for us?
I sure do. The first question is from Pamela Williams, and she says, I have MS and an open wound on my right ankle for about 4 months. I keep it clean with peroxide and I put Bactracin on it nightly. I bandage it up every day, but it won't heal. What can I do?
So someone has MS, they have an open wound, they take care of it at home every day, and it's still not healing. What do you suggest for her?
I think first and foremost is getting to a specialist, getting an x-ray to see how close that wound is to the bone or the outer covering of the bone. Sometimes you can have a wound that's so close to the bone that it touches that saran wrap around it. Sometimes we call that periosteum. And then if that periosteum gets infected, then that could seed infection into the bone. If a bone is infected, not to say, Pamela, that you have an infection in your bone, but it's certainly something that we want to be aware of and really make sure that it's not the case, because ultimately that might become a surgical consideration where that might have to be biopsied. And then from there, what we can do is we can then get x-rays to see, is there a deformity there where maybe because of your MS, the bone is pushing against the skin so much that it's not able to heal because you've got pressure from the inside as well as pressure from the outside that could be contributing to that wound. So the bottom line is, it has to be evaluated, recommend x-rays, labs, and getting an appropriate evaluation of the wound where maybe there is too much of that inflammation going on, whether it's from infection or maybe too much of that fibrous tissue going on that we may need to clean up and then get the wound to heal. Some other things we can consider are, once the wound is healing, it's red, it's healthy, then from there we can go ahead and we can maybe treat it with some skin graft substitutes or even try to do some bone work, realign the foot, get rid of the deformity, which is the underlying cause, and then close the wound primarily.
Great. Do we have any other questions?
Yes, we have one more. Donna Valar says, I am diabetic and I have 2 blood clots in each leg. Normally when I get a sore, I wear a cast and the sore heals faster. But now I can no longer wear the cast. Any suggestions?
So what they're describing is a total contact cast, which has been shown to have great efficacy in offloading and healing wounds. And what that cast is it's something that provides full support in a total contact fashion. So the surface area is increased, because the lower the surface area, increased pressure you get. So the goal of the total contact cast is to offload those areas and provide cushioning and support while also allowing the foot to be suspended. Unfortunately, what she is describing when you have multiple blood clots is something called post-phlebitic syndrome, which can cause things to swell very much, because what happens is those clots prevent the blood from being drained up to the heart. I think, in this particular case, probably controlling the swelling would be the best thing for her. I recommend in this case seeing a vascular surgeon, seeing if there's any procedures that can be done to help increase the flow of blood getting back up to the heart, and then thereby maybe tolerating total contact casting more. Or there's other alternatives. There are different kinds of bracings out there that you can actually suspend the foot in a clamshell design and actually prevent any pressure from being put onto the foot or ankle. I certainly would monitor the swellings. I think that's the biggest cause of these sores, because the more swelling you have, the more shear you're getting on the skin. The total contact cast is awesome. There have been studies that have shown actually that people that are offloaded with just a walking boot, sometimes called a CAM, C-A-M walker boot, isn't as effective as total contact because unlike total contact, you can take off the CAM walker boot. The best patients enrolled in this study, the most motivated, only wear the boot about 30% of the time. So I think that obviously, using what you got is very important, and the total contact cast really helps the patient become an active participant in their care by allowing them to really offload that wound. But certainly, I think if you have a history of clots, you probably don't want to be immobilized for a long period of time because those can make those clots worse. And certainly being on anticoagulation therapy and definitely touching base with a vascular surgeon, whether it be at University of Maryland or anywhere else, I think would be a great benefit to this patient.
Do we have one more question?
Sure. Kimberly Rollins asked, I would like to know if it's okay to have hardware in your ankle over time if you are pre-diabetic.
So hardware in your ankle when you're pre-diabetic. What are your thoughts?
I think that's perfectly okay. I think that if the hardware's there and there's no distinct deformity, meaning that your ankle is not tilted one way or another, or there's hardware in your foot, I think that's perfectly reasonable. I do a lot of foot and ankle reconstructive surgery as well, and oftentimes I will leave hardware in indefinitely. Titanium is typically used in some cases because it provides less artifact or less abnormal signal if you get an MRI, but all implanted hardware should even be MRI compatible provided that it's fixed and it's in there. The main reasons to remove hardware are if it's sticking out, if there's substantial deformity that's resulting from broken hardware, or if there are signs on x-ray that the hardware is sort of loosening or about to break, because usually that can cause a cascade of events. Although, that being said, there's some literature on ankle fractures that show that patients even sometimes do better when the hardware breaks. So my quick answer to that is probably no, unless you develop neuropathy or significant deformity. And neuropathy, again, is when you lose that protective sensation, meaning that you can't feel the foot or ankle as well, and you're more likely to not be able to adjust. It only takes about 2 hours of pressure to get a sore. So if that screw or plate is pushing against the skin, then that too can cause a problem and also cause rubbing and irritation, and for that reason it may need to come out. I would definitely monitor and see if you have any redness or signs that the wound could be opening up, and in that case I would definitely take out the hardware, especially if you're pre-diabetic and your A1C is well controlled. The other thing I'll mention to all of our pre-diabetics out there is you're actually at a better time that if you do notice something abnormal, to go to a foot and ankle specialist or a reconstructive surgeon such that you're able to address the issue before your blood sugar gets out of control. A blood sugar that is with a hemoglobin A1C greater than 8% has been shown to have worse outcomes with foot and ankle surgery, so that if you are in the ballpark under 8% and there is a distinct issue going on, I definitely recommend getting it addressed sooner than later.
For our viewers who still have questions about non-healing wounds, please leave them in the comments section under this video, and Dr. Wynes will get back to you within 48 hours. Dr. Wynes, how can people schedule an appointment at the Wound Healing Center?
The easiest thing would be to pick up the phone. The phone is 410-225-8600, I believe.
Great.
I mean, obviously, you could also schedule through the Orthopedic Call Center at 410-448-6400, which will get them in touch with my practice, with all my other locations. And certainly we can figure out where the best place and the best course of treatment would be for this individual.
Great. Thank you for your time. Again, you've been watching Dr. Jacob Wynes, instructor of orthopedics and wound healing specialist at UMMC Midtown campus. And thanks to all of you for watching.